Okay, Marcy, I think we're ready when you are.
Okay, go ahead.
Okay, so today we have with us Dr. Troy Morrison. So he's actually board certified and fellowship trained orthopedic spine surgeon. He grew up in Southeast Missouri on a dairy farm, completed his undergraduate degrees at Drury University and graduated medical school from Kansas City University of Medicine and Biosciences. So we have several of them here with us today. He completed his orthopedic surgery residency in Warren, Ohio, and a fellowship in spine surgery at Texas Back Institute. So I will go ahead and share the screen. Okay, are you all seeing that? Somebody give me a thumbs up.
Yeah.
Okay. Okay, and you've got the clicker. Yep. Okay, we're good to go.
Thank you all for having me. I'm very honored to be here and contribute to your medical education. I remember when I was a third-year medical student, had to spend my Fridays doing the very same thing. But today I'd like to talk to you about nutrition and patient optimization. Patient optimization in surgery is probably the hottest topic right now, especially with the onset of bundle payments and value-added healthcare. Cost containment and improved outcomes is the #1 thing we hear about in our society meetings. The objections of today are for you all, the audience, to recognize patients that are at risk for nutritional impairment and optimize the patient's nutritional status with an evidence-based approach. So nutrition is something that we're involved in every day. It's a very important part of our everyday life, even our pet's life. When our pet is sick, we give them something special, some nutrition formula if they have arthritis or if they get old. But that's not so in healthcare, especially in the United States. In every aspect of our lives, nutrition is important except for our patients. And that's interesting because the father of modern medicine, Hippocrates, said himself, our food should be our medicine and our medicine should be our food. When I was in medical school, I got 0 lectures on nutrition. It just wasn't considered important. We did hear a lot about modifiable risk factors for complications like diabetes, smoking, and obesity, but we were never taught about nutrition, which is interesting because in the United States, up to 55% of patients admitted to hospitals are malnourished. And what's worse is 69% of those patients will leave the hospital more malnourished than what they were when we admitted them. Looking at specifically orthopedics and spine, because that's what I do, both orthopedic surgery and spine surgery. Just in the last 2 years, over 20 articles have shown malnutrition to be the #1 independent risk factor for postoperative complications. And yet, we still very seldomly hear about it. Here's one of the studies that I'm talking about. This retrospective review of over 4,000 lumbar fusion patients. They looked at malnutrition as an independent risk factor. They defined malnutrition as an albumin level of 3.5 or less. And they found that patients who were malnourished were significantly more likely to have a surgical site infection, wound dehiscence, post-op UTI, post-op sepsis, hospital readmission, and increased length of stay. There's another study on a different patient population, revision total knee arthroplasties, again, over 4,000 patients. They found the exact same thing. Patients who were malnourished were much more likely to have any complication, wound infections, deep surgical wound infection, pneumonia, UTI, acute renal failure, and sepsis. There's another one with a different patient population, anterior cervical fusions. They defined malnutrition the same as an albumin level of less than 3.5, and they found the same thing. Patients who were malnourished were much more likely to have postoperative complications, readmissions, reoperations, longer length of stay, with a relative risk of any complication of 3.4. There's another study, a huge study with a full 100% sample of Medicare data from 2005 to 2012, showing the same thing. Patients who were malnourished were much more likely to have a complication, odds ratio of over 4, wound dehiscence, surgical site infection, and death with an odds ratio above 6. Readmissions, here's another study on spine patients, looked at readmission rate after spine surgery. The authors found that patients who were malnourished were much more likely to have postoperative complications, longer length of stay, and were 300 times as likely, the readmission rate was 300% more if they were malnourished. There's another one, 1,500 patients, this time posterior cervical fusion patients, found the same thing. Patients who were malnourished were more likely to have any complication, postoperative complication, increased length of stay, sepsis, blood transfusions, blood clots after surgery. And what's most interesting about this study is they also looked at obesity, BMI, as an independent risk factor, and diabetes as an independent risk factor. And they found that when you exclude malnutrition, patients with a high BMI and patients with obesity or diabetes did not have an increased risk of postoperative complications. That's significant because that's not what we've been taught. At least that's not what I've been taught. I've been taught obesity and diabetes increase the risk of postoperative complications. This study says otherwise. So does this study. This is a study of over 4,000 anterior and posterior cervical fusion patients that evaluated the incidence of malnutrition, and they found that over a 30-day period, malnutrition increased the risk of mortality, DVT, PE, sepsis, infections, blood transfusions, length of stay, and reoperations. They also found that a high BMI, regardless of the class of BMI, that means even patients with a BMI of 60, was not associated with increased complications within 30 days. Here's another one that shows the same thing. This time, it's over 77,000 total knee replacement patients. They looked at obesity as an independent risk factor and malnutrition as an independent risk factor, and they evaluated them for 21 different complications. They found that obesity was only associated with an increased risk of post-op acute renal insufficiency, superficial infection, and sepsis, while the patients who had malnutrition had an increased risk of mortality, superficial and deep surgical site infection, post-op pneumonia, unplanned reintubation, septic shock, acute renal failure, acute renal insufficiency, cardiac arrest, and blood transfusions. Here's yet another one that showed the exact same thing, this time over 20,000 total hip replacement patients. They found that malnutrition was a more robust predictor than any class of obesity for any postoperative complication, any major complication, respiratory complication, blood transfusion, and extended length of stay. So undoubtedly, with that evidence, malnutrition is an independent risk factor for postoperative complications, and arguably the most significant. But can we modify that? Can we do something about it? What are our options? What can we do? We can have a dietary consult. We can convince our patients to change their daily diet. That would be like convincing them to quit smoking or lose weight or control their diabetes better. We can give them something, anything, Boost or Ensure or any protein shake, or we could use an evidence-based approach and give them something that's been proven to make a difference. And that something is immunonutrition. Immunonutrition is a combination of immune modulating elements, arginine, glutamine, omega-3 fatty acids, and nucleotides. Immunonutrition is not new. It's something that's been around since the 1990s. In fact, if you do a PubMed search on it today, you'll find over 650 articles about immunonutrition and its efficacy. That's a lot more than most of what we do in medicine today. Here's a good summary of that data. This article was published in 2016. It summarized randomized controlled trials to the tune of 173 randomized controlled trials, all showing patients who received perioperative immunonutrition had fewer postoperative complications and shorter length of stay. That's a lot of randomized controlled trials. And here's what they showed. This one showed patients who had immunonutrition prior to major surgery had a 51% reduction in postoperative complications and a 15% shorter length of stay. This one showed the same thing, over 1,000 patients, 50% reduction in postoperative complications, shorter length of stay. This one was a prospective randomized double-blind multi-center trial which showed the immunonutrition group, patients who had perioperative immunonutrition had 50% fewer complications. And the cost of complications was significantly less in those patients, 75% reduction in cost of complications. Here's another one that looked at immunonutrition in patients who were well nourished. They excluded malnourished patients. Those patients underwent a lung resection for non-small cell lung cancer, and they found that the immunonutrition group, those patients were more than 50%, or they had 50% of them had less complications, and they were able to get out of the ICU 2 days sooner because they could pull their chest tube 2 days sooner. It's another one that looked at well-nourished versus malnourished patients. It was, again, a prospective randomized double-blind clinical trial. They looked at all the patients, immunonutrition versus not immunonutrition perioperatively, and they found that the immunonutrition group had 50% reduction, actually 54% reduction in postoperative infections. Then they divided those patients out to well-nourished versus malnourished, and they found that in both groups, well-nourished and malnourished patients had a 50% reduction in postoperative complications. So they concluded that regardless of baseline nutritional status, perioperative immunonutrition significantly reduced post-op infection. So what do we now know? We now know that malnutrition is a significant and arguably the most significant risk factor for postoperative complications. And immunonutrition decreases complications and improves outcomes, with over 600 articles that prove that. What about the cost? What are we risking? Well, let's talk about the cost of complications first. This study looked at over 5,000 episodes of care for 24 different surgical procedures. They found that the mean hospital cost for patients who had complications was just under $20,000 more, or 120% higher than patients who did not have complications. Readmission rates. Readmission rates, national average for a 30-day readmission rate is just under 20%. 90-day readmission rate is 34%. That's huge. That means 1 out of 3 patients that I admit will be back in the hospital in 90 days. 1 out of 5 in 30 days. That's a lot, and that's expensive. How expensive? The average cost of readmission in the United States is about $11,200. For total joint replacements, it's even higher, $12,300. For congestive heart failure, even higher, that's the most expensive, $13,000. And in this study, the readmission rate, 30-day readmission rate, was over 25%. Here's a big study. This is actually a brief out of the Healthcare Cost and Utilization Project from 2013. It's the database of 5 national databases. They capture about 90% of hospital admissions in the United States. And they looked at malnutrition and the readmission rate and the cost of readmission with malnutrition. They found that patients without malnutrition, their 30-day readmission rate was 15%, and their cost of readmission was $13,400. Patients with malnutrition, the all-cause 30-day readmission rate was 23%, and the cost per readmission was almost $18,000. They further divided that up with the average cost of the index admission. Then they divided it out into the cost of the readmission. And then the overall total cost for patients who were malnourished was almost $12,000 more, which if you look, that's how much the average cost of readmission was, or the average cost of the index admission for patients who were not malnourished. Readmissions are a big deal now. CMS penalizes hospitals for readmission rates. In 2017, over 25 hospitals in the United States were penalized for their readmission rate. to the tune of more than $500 million. Hospitals also get penalized for hospital-acquired infections. There was almost 800 hospitals in the United States penalized in 2017 to close to $500 million. And immunonutrition changed that? The answer is yes. Here's a study that shows that a meta-analysis of almost 1,000 patients that shows that immunonutrition reduces the cost per patient based on length of stay by $6,000 and the cost per patient based on reduction in infections by $3,300. So immunonutrition can optimize patients. Nutritional status is one of the most significant risk factors for complications. Malnutrition or nutritional status is truly modifiable. We don't have to ask our patients to change their lifestyle like we do if we ask them to quit smoking or lose weight. The solution is as simple as taking immunonutrition 6 days before and 6 days after surgery. Immunonutrition also saves the hospital money through fewer complications, fewer readmissions, and shorter length of stay. So what's our role in this? As physicians, our role is to educate and advocate. We need to discuss the risks of the treatments that we propose to our patients, discuss the risk factors associated with those procedures that we recommend, and also we need to discuss how to mitigate the risk of potential complications with our patients. And for those who can't afford it or don't have access to it, we also need to advocate to our hospitals and health systems because they also have better outcomes, which means fewer costs and better quality for their patients. Just like this study. This study is a cost savings analysis with patients who had immunonutrition perioperatively, and it showed that hospitals saved $2,619 per patient if they put them on immunonutrition perioperatively. So my protocol, I mentioned 6 days before and 6 days after. And I recommend immunonutrition for my patients who have who have elective surgery. 2 bottles a day, 6 days before and 6 days after surgery. If it's non-elective, like a hip fracture, we can't have them take it before, so we have them take it either 6 days or 12 days postoperatively based on their nutritional status. So optimizing patient nutrition, I think, is the most significant thing we can do for our patients to improve their outcomes. It helps our patient outcomes, it helps our outcomes as physicians, and it helps the hospital outcomes as well. And that's all I got for you. Is there any questions?
What does it taste like?
It depends.
Like people always complain about their colonoscopy preps and things like that.
There's 3 products on the market with multiple flavors. It is medicine, so it doesn't taste great. Some taste better than others. So.
I may have missed this on an earlier slide, but I know you mentioned albumin as a quantitative definition of nutrition or malnutrition.
Mm-hmm.
But are you using I know there's the updated Aspen protocol or the Aspen definition of malnutrition? How are these studies quantifying malnutrition in a codable way for patients?
So the most common way is albumin. Albumin is not as acute phase as prealbumin. Prealbumin actually is more sensitive. There's just not a lot of patients out there with data retrospectively with prealbumin, although there's more and more studies showing prealbumin of less than 20 significantly increases the rate of complications. Transferrin is also another objective marker. And there are multiple nutrition assessment scores that looks at body fat index, oral intake. There's a lot of variables there that can become pretty cumbersome. If you want to do a study, it sounds really cool. If you want to do it in practice, You got to find something a lot easier than that. And that's how we do it in practice. Albumin, pre-albumin is probably the most common ways.
Do you think there's a place for immunonutrition in non-surgical inpatient stays?
Yes, there is. There's actually studies on that as well. And it shows, in fact, one of those studies, I think, for the cost effectiveness, that last one I showed, I think, of a $2,000 cost savings, those were on medical patients, not surgical patients.
What is the cost for a 12-day course?
It's between $100 and $200.
I mean, this might have been in your slideshow, but are you currently using this on like outpatient procedures as well?
Yeah.
As inpatient procedures?
Not so much outpatient. Sometimes athletes, like if I do an ACL reconstruction, they want to get back really, really quick. They want to do everything they can to get back, then they'll use it. So not as common with outpatient, but that would be somewhere where it's used more frequently.
With the ingredients for the immunonutrition, are there any different formulations that have been found to figure out better?
So there's been a lot of different formulations. Most of them were developed in the 1990s. There's a lot of them. That's one of the downfalls is there's not a consensus of the best formulation, just because a lot of the meta-analysis throw a lot of different studies in there with a lot of different formulas. The ones that have arginine and omega-3 fatty acids have been studied most extensively, and those are two that absolutely have to be in there to be effective. There's only one on the market right now that has glutamine in it, and that's the fourth and probably the second most important ingredient or immune modulating element in immunonutrition. So I think the combination of all four is crucial: arginine and glutamine, omega-3 fatty acids, and nucleotides.
Are there any contraindications to use or patient populations that are?
Yeah, patients who are critically ill with sepsis. There was a study done that showed if you give them more than 10 grams of arginine a day, there's an increased chance of mortality. So if you have a patient in the ICU with sepsis, that's one you should not give it to.
You have dietitians that help you kind of determine who needs what?
No, it's pretty straightforward. They either need immunonutrition or they don't. And actually, studies show, like the ones I showed, even well-nourished patients benefit from immunonutrition. We do have dietitians at my hospital. Most dietitians that I've talked to don't know about immunonutrition, just like the vast majority of physicians don't know about it. In fact, probably 99% of physicians don't know about it, even with over 600 published articles, even with over 20 articles published about malnutrition in the last 2 years, just in spine and orthopedic literature. Just something that's been overlooked for so long. We just tend not to think about it.
What made you start doing it?
So it was something in my residency, I was working on a research project unrelated, and I just stumbled across an article about it, and I read it, and I was intrigued because it sounded like it worked really well. So then I read some more articles about it, and they said the same thing. So then I started looking for the product, and I couldn't find it. And I thought that was even more interesting. Something that's supposed to work so well is invisible. And that intrigued me so much that I spent the last 8 years researching it. So, and the last thing I want for my patients is a complication. patients come to me to fix them. If I make them worse, like a post-op infection, epidural abscess, or something like that, post-op infection from a total knee is devastating. You have to take the total knee out. You have to put an antibiotic spacer in there. They get IV antibiotics for 6 weeks, and then you got to put a new knee in them, and that second knee never works as good as the first one. So if you can imagine, that's you having 2 operations instead of 1, laying in bed in a nursing home getting IV antibiotics for 6 weeks. I'm going to do everything I can to avoid that.
I have a general question about this. It always seems to me that nutritional research is a double-edged sword, where there's a lot of it out there and it can be really powerful, but I'm always finding contradicting studies. And I was wondering, I mean, I know that's one reason why it's not taught in medical school a lot, because there is so much conflicting research. And so what would you recommend us say as a way to support this sort of research if we have colleagues that are a little speculative?
So that's a very valid point. In fact, I was just talking about that yesterday to somebody. Someone told me they were on the keto diet and they lost a bunch of weight. In the keto diet, you're supposed to eat fat. You're supposed to eat fat to lose weight. Sounds a little contradictory in itself. You can find a diet that contradicts a diet all day long. Some people think, some dietitians or probably nutritionists think milk is the devil one day and then sugar is the devil the next day, and then certain carbs are, certain carbs aren't. Part of the problem is that research is not as well controlled as medical research. A nutritionist, you don't have to have any training or any certificate to say you're a nutritionist. You just say you're a nutritionist. A dietitian, you have to have a certificate to be a registered dietitian. But that makes it very hard to know what research is valid and what's not. The difference with immunonutrition is the articles in medical journals prove it on real patients. So, and the articles, especially recent articles about malnutrition, they're done very, very well. They're big studies, like some I showed you. There's one study that had 1 million US patients in it. There's another one with 77,000 US patients in it. So if you look at the data from reputable medical journals, good studies, that's what you can show your preceptors and your colleagues. Yep.
Have any of those studies shown a decrease in post-op opioid use due to like perfusion?
That's a hot topic, but too recent of a topic to have articles published on. None that I know of.
Are a lot of the surgeries that you do elective?
Yes, a lot of them I do are elective. Probably about 80% of them. Which is nice because then I can educate my patients about it. And that's the key, letting patients know. Someone asked the question about cost. A lot of physicians that I talk to about this are worried about the cost, and they tell me their patients won't pay for it. Would you pay for it? Seeing all the evidence I just showed you, is it worth $100 or $200 for you not to have an infected total knee, have to have a revision, and 6 weeks of antibiotics in between? I think that's worth $100 to me.
Is that all out of pocket?
It depends. Some facilities furnish it for their elective surgery patients, especially colorectal patients who are having colon resections, some total joint patients, some spine patients. But most of the time it's out of pocket. All righty. Any other questions?
Are there any questions out at the other sides?
have a question. What do you do with people who do have GI surgery who aren't able to eat, with possibly ileus or nausea, vomiting complications? How do you give this to them?
You can't give it to them in a feeding tube. But oral nutrition is much better. That's kind of oral, but much better than parental. Try to get them oral feeds as soon as possible. But if they can't eat, you can use it in a feeding tube as well. In fact, actually, that's how it was first developed, as a tube feed.
Similar mixes that would work for like TPN patients or anything like that?
Yeah, they do. Mm-hmm. Yep, and that's
similar success rates. Right?
Yeah, it does. Yeah, in the 90s, that's kind of how it came about with critically ill patients who needed TPN. That was its first role. But we see that less and less now, because now we're feeding patients even before surgery and much quicker after. We used to think that if you had a colon resection, you needed to rest your gut for days and days, which, if you think about it, doesn't make any sense at all. The quicker you get of nutrition, the better. Any other questions out there?
Okay.
All right. Well, thank you very much.
Thank you.